We've heard today about how to acquire data, clean data, make sure it's acceptable to the legal authorities. We've heard about the risks and benefits of using data. And now in this learning, in a learning systems model, we want to understand how we can then take this data in our learnings and then implement them to our community to make outcomes better. The three speakers today sort of highlight, I think, innovative approaches and lessons learned about how to do this better in this learning sort of model. And so I think we'll have the three talks, no questions, then we'll have this really interesting panel discussion. This is, for me, the highlight of the entire day because this is lessons learned, this is real-time stuff, this is like boots on the ground approaches on how to take all the stuff we're learning and then basically help to change our patients' actions. So first will be Sunny Liu from the social media lab, then Alok Patel from the Department of Pediatrics, and finally Sara Cody from the Department of Health in Santa Clara Valley. So, Sunny?
Okay, thanks so much.
Oh, yeah. So Sunny's the professor in the and runs the social media lab, really focusing on adolescent health and social media. So, Sunny?
Okay, thanks so much, Tony, for the introduction. I really feel pleasure to be here, especially serving with all those amazing panelists. Today, I want to focus on adolescents and their information ecosystems. So if you think about today's social media, it's very different than 5 years ago, 10 years ago. So lots of the most popular websites, such as TikTok, YouTube, and Instagram, they actually are hosting short video format. Those are usually content in short videos from 15 seconds to about 3 minutes. On average, all those adolescents we have, they spend a lot of time on those social medias. For boys, it's about 3.9 hours on those three platforms. For girls, they're about 4.3 hours. So all our adolescents, they take a part-time job each day on those social media sites. So the question I'm interested in is what's their experience? If they are doing those part-time every day, so what they get and what they encounter. So for this research, it's really, let's see what you certainly can encounter on those platforms. Here's one.
5 things as a nutritionist I would never consider putting in my body. Number 1 are sodas. Sodas lead to thinning bones because of the phosphoric acid. It also has been directly connected with obesity. Sodas don't have a place at my table. They shouldn't on yours either. Number 2 is aspartame anything. There's all kinds of neuropsychic issues that are connected with that, including headache, convulsions, you name it, it's connected. We don't need that use. Instead of using aspartame, start using things like monk fruit or anything, but not that. Number 3 is margarine. Margarine is not, it's not even fake butter. It's just fake crap, period. Let's just have some respect for the cow and put butter on our toast again. Can we agree to that? Please, margarine, no. Number 4, anything that has a box that says natural or low fat or anything like that, what that is, that's code for crap. Because inside of that box is all kinds of garbage, which leads me to number 5. And that is anything on the box ingredients that is unpronounceable is not going to go into my body and shouldn't go into yours either. Do you know what half this stuff is? If you don't know what it is, you shouldn't be eating it. Our bodies understand what food is and will eat, and can deal with that. It can't deal with unpronounceable chemicals.
Okay, so for this creator, so she has about 1 million likes and about 150K followers. And some of the things she mentioned, as I think that this amazing audience, for example, those unpronounceable items here, they're actually vitamins or caffeines. For this specific type of videos we just saw, actually she got more than 200K likes and more than 21K forward and more than 26K saved. And in the comment section, we can see that the younger youth, they ask her questions like, what's the best food for healing a broken bone? And what's your recommendation for losing weight? So that is what adolescents sometimes encounter on those platforms, the content here. So what I want to study is two things. First is what's the information they encounter on those information jungle. As Tony mentioned, the truth and misinformation has become really hard to discern. So what type of information they see on those platforms? And what do our adolescents do with it? So when they encounter those information, what's their strategies? What's their actions? The best way to find answers to those questions actually are by talking to adolescents. So we conducted 33 in-depth interviews with a diverse population of adolescents, pretty much ask about what do you see on those platforms and what do you do. So here are some high-level findings. First is what do they see? It's actually first is their content engagement are really driven by interest, and they do encounter both beneficial and harmful content. The first one specifically is those kids spend about 4 hours each day, they only consume very narrow type of content. Only usually about 2 or 3 type of their interests. Could be K-drama, could be K-pop, or like diehards, cosmetic, or dance. So each of those interests are really distinct and personalized. So you ask the 2 kids, they tell us very distinct things. Some are interested in jokes and sports. Others actually are only interested in watching about life hacks or different things. And those narrow content consumption patterns makes them, they're in those tunnels, they don't get out of those tunnels. We talk about lots of content. A surprising findings, I thought, is really the fleeting nature of the content. Many of those adolescents told me that as soon as they close their app, they forget what they see. So those have implications for think about the creators and the content consumptions. The next thing is about type of content, beneficial or harmful. Most of them find useful content. Maybe it's about some educational materials. Maybe it's about life hacks, how to fold toilet papers. But they do encounter harmful ones. So this was one girl's experience when she was 13 years old. She was, I think that time she was, I think that it was YouTube. It was guy killing himself. I was pretty traumatized from that. It was clickbait. Or it was on Instagram. They put a picture of my little pony, and I love little pony. And I click it, and it was a video of that guy, you know. And I cried for a little bit after that. There was a lot of video like that going around when that video was uploaded. 13-year-old, a girl, trying to watch a little pony. And here's other ones too. So this is a little bit older, I think that 15-year-old girl told me that my friend was using my social media for a while, and she has an eating disorder. And one way that she copes with it herself was she going on to eating disorder communities on social media. That's her way of coping with it. And I was completely fine with that. She follows a couple of accounts that post anything related to using my account. And I was like, sure. But ever since then, my algorithm has not moved on. It's been over 2 years since then. They still give those kind of content. That's definitely something I will screw over. After 2 years, and those content, specific type of content still show on her feed. So if you think about what the kids encounter, they encounter all those content really driven by algorithms, matching exactly their interests, and they encounter both beneficial and harmful content. So the next question is, when they see those content, what do they do? Do they talk to parents? Do they ask teachers? Or how do they even fact check? So first findings is almost all our participants, they just through scrolling past those content. For them, it's just not engagement as a way for action items. And the most frequently scroll past the content are not harmful content, but news. More than advertisement, more than sponsored content, our adolescents, 2/3 of them actually, whenever there's some news and information, they scroll past all those informations. They have reason for that. I already get enough that from reading the newspapers and watching the news and all. I just kind of want to de-stress. And they also scroll past content that they deem emotionally heavy, particularly around violence, shooting, and mental health. Videos that teenagers post at the lowest point in their life, and they're crying, and lots of mental illness. Those are really sad videos. So most of our participants, their action is passively non-engagement. Then we do have some participants, actually, they do use ways to trying to do check for credibilities. So they use first is creators' attributes. So whenever we think about credibility, we will think about, we want to check about their credentials. Are they a pediatrician or not? What's their credential, their education, their organizations? For adolescents, the cues they get are not those. They use familiarities and communication styles. If they see those creators a couple times, they think that they're trustworthy. And if they see that they use certain ways to communicate, then they use that to evaluate credibilities. So here's one kid tell us that there can be something when they start find other words, they're trying to describe what they want to say. I will immediately say, oh, they're just thinking about, they're not telling the truth. That's not how usually experts communicate. When when you see a patient, you will think, pause, and then explain the answers. But for those young adolescents, whenever they see a creator think, pause and think, that also means that they're actually not credible. And they also use comments there. So they check other comments, you see if there's something on those posts, on those videos, and then other people point out, that means that they can check for that. So those are the ways they check for credibilities. All our participants, they will never get out of the app to do fact check. In our ways to think about digital literacy, media literacy, we'll always encourage kids to pause, go to fact check, and then search, do lateral reading or different search. But most kids, they do not do that. Reason simple. It's really they think that it's not really affect their day. And when the 5 participants tell us that they will do fact check, but they only check the things really matter to them, those are sports scores. So those are only things they think that is really important. They want to fact check. So it's really, I think that for kids, fact checking seems that's nothing they do. The next one is really think about, do they talk to parents? Do they ask for adults? Only some people actually they'll talk to their friends, but only 1 out of all the 33 kids, they will actually talk to their parents and ask. That is the ones they do. So if you think about all the actions our adolescents do, so their most strategy is selective passively not engage in this content. And they also don't use in critical evaluations. And they actually rarely do off-platform strategies. So what's the main findings we have here? It's really, I think that those social media systems our kids spend lots of time on each day. It's actually present a really both simple and complicated information ecosystems. The real, I think, that challenge for us is really think about how we can support adolescents, their healthy engagement on those platforms, and to nurture their digital literacy, media literacy, and critical thinking skills. Then what can we do? What's the main takeaways here? So how we can move away from the videos we see that have more than 1 million likes and followers, to that we can provide them with trustworthy information, better information. So there are I think there are 4 things. First is about harmonizing. In offline world, we built those circle of care and protections for adolescents. So we have all those pediatricians, we have schools, we have parents, we have neighborhood. But there's no those digital ecosystems and circle care for adolescents. When they're on those platforms, they're by themselves. There's no protective mechanisms there. And second is if we want to really communicate to adolescents, we know sometimes family will not work as well as when kids are younger, and schools might not even be the best way. So it's really meet adolescents where they are. They spend a lot of time on those platforms. It's really working with those platforms and make platforms accountable for the information they provide. That is, I think, that one of the solutions. And for pediatricians, be part of those ecosystems. Put the content that we want to share with adolescents there, and be part of that, what they can see, and see a few times, so they will see that, this one looks really familiar, and I can trust. Be part of that ecosystem. And take advantage of the generative AIs. Today's morning, we heard lots about AIs and what they use. One thing that has not been covered in the morning session is about one thing generative AI is really good at is those personalized and individual-based narrative nudging. If you think about previous communications, when we develop a communication plan, it takes huge amounts of efforts, and it's hard to reach diverse communities of different types of adolescents. Now, with different prompting technologies and techniques, we can use generative AI to effectively communicate with kids both from Central Valley and Bay Areas. So those are the advantage I think we should take off. So here are the main 3 or 4 takeaways: harmonizing and meet kids where they are, be part of the ecosystems, and also using technologies to advance our information delivery systems. So thanks so much, and I look forward for further discussions about the topic.
Thanks so much. Really intriguing and disturbing at the same time. Our next speaker to provide is Alok Patel. He's a hospitalist here at Stanford and the faculty director of communications for the Department of Pediatrics, medical communicator, and really has that interface between medicine and the community to provide his perspective. Alok?
For better or worse. Is my mic on? Rock on. So this is my clicker. If Mary pulls the plug and says, you're out, leave the room, as long as you all remember this title, I'm happy. Because this is what it comes down to for me as someone who's trying to translate what is happening in the hospital versus what we want the public to know. It's just adding that little extra sauce to get people to pay attention. So, controversial question to ask right now. Who has a favorite conspiracy theory? Anyone? I know we're talking about combating misinformation. I'm over here promoting it. Someone raise their hand. What is your favorite conspiracy theory? You went dark. I was thinking something lighter, like that dinosaurs are fake to test people's faith in God. Something fun, but you went dark. I really want Area 51 to be real. I don't want to go to the desert and see that it's nothing. I want to know the aliens built the pyramids. The entire concept of conspiracy theories, whether it's chemtrails, or we're talking about vaccines, or that we get paid off by big pharma, which where is my paycheck? It all comes down to this. This is what it boils down to. Is what misinformation, what conspiracy theorists do so well is they evoke our emotions. There's emotional valence. They're entertaining. They tap into that part of human psychology that is unchanged for thousands of years, that it gives us psychological satisfaction. It's angry, it's sensational, it's entertaining, and it reinforces beliefs we already have related to our culture, our politics, and the people around us. This is an elegant chart. I know I had to get a little nerdy here today from Nature magazine, about all the different factors that play into why we have a psychological draw to information, whether they're socioaffective drivers or cognitive drivers, tapping into everything from our intuition to the fact that we want to problem solve, to the fact that we want quick answers, to those TikTok videos we just saw about how you can get rid of all your health problems by not having any chemicals in your body. Quick answer. That's not how science works. But that is how human emotion works. And this is what gets all false beliefs to have that extra emphasis. Tools that we can all use when it comes to storytelling and sharing our information with the public is first thinking, why exactly does misinformation, why do these ghost stories work so incredibly well? What are they tapping into that science can borrow something from? Who can guess where this picture, what date this picture is from? Could be yesterday. Any guesses? It would be from yesterday if yesterday was 1885. This is an actual misinformation campaign in Montreal during a smallpox epidemic. Here's what's wild about this. Misinformation and persuasion techniques are one of the only unchanged behaviors throughout all of scientific discovery and everything that we've done over the last few centuries. This could literally be a campaign about anti-vaccine propaganda, people being forced to be vaccinated. The other thing we mentioned, aside from emotional valence, is a quick answer. So I know that this article is not applicable to any of the guys in here because we already have six-packs. Why is this clickbait? Aside from the gentleman, it's clickbait because it's a beginner's foolproof guide to six-pack abs. There is a quick, actionable item, which once again is something that we can do when we think about pitching stories. What do I want my audience to do with this? My audience may not understand my clinical research, but what is the takeaway? Do I want you to vote differently? Do I want you to pay attention to science? Do I want you to follow a healthy diet? Do I want you to donate to Stanford? There is a takeaway item. Maybe it's not foolproof, quick abs, but it is something powerful. So when it comes down to taking these stories and saying, what can we borrow from the entertainment industry? These are the three most important things I've learned over my media career, from comedians, from TV anchors, and from producers. Actively listening, making things newsworthy for our audience, and telling stories. I've worked with all three of these incredible people. Diane Sara changed my entire life. We'll get back to her. So as part of my work with ABC News and in journalism, I've learned that everything can be controversial. Everyone has a strong opinion about topics. And we are no strangers to misinformation, whether it's related to the COVID-19 vaccine, which we were all over it, right? To even things related to climate change, to gun control, to funding, to what exactly is happening with the Baxter facility and IV fluids. Yes, there's a controversy there as well. But when it comes to mainstream media, you take that information, you say, okay, how can I be evidence-based? How can I be nonpartisan? And then make an actionable item for the audience. And we can often do that with humor, by inviting the audience to come with us and actually hear their concerns, by being audience-centric. This is a segment that I host on ABC News called Patel It Like It Is. It's the best use of my last name I've seen in healthcare. Just kidding. But oftentimes, it comes down to more than humor. And it comes down to this removing ourselves from the false assumption that we're living in an information deficit. Or if I just give people information, that they then will say, oh, okay, no more misinformation, I've got the right tools. It's beyond that. It also comes down to getting the right information ahead of time, something that we call pre-bunking. You got debunking, which is very reactive. We want to be proactive. And part of that comes from building trust, which we can do by admitting things such as, I don't know, we were wrong, and having humility, which there are many ways that we've also done that in mainstream media. By saying, let's go back and look at mistakes that we've made in the past. How are we learning from them? How are we talking to the key stakeholders, the patients who are affected, to admit that this is a continuum, regardless of the topic that we're all looking at? And the takeaway, when we approach stories from this, is to always realize that audience is everything. When we're speaking to a room of people, there are those who are never going to agree with you. There are people in the audience who will say, regardless of what you say, I have made up my mind. There's also the echo chamber, which is like really fluffy. We all like an echo chamber, right? I want to go into a room and speak to someone and know that everyone agrees with me. We got them, they're good. I'm looking at the audience in the middle. The audience in the middle who might be impressionable, who I need to really pay attention to and understand their demographics, and then identify what do we want them to do, what actionable item. So the first tool we're going to talk about is actively listening. And people who do that extremely well are comedians, who take the same content, do the same set, but in a different city or a different room and look at the audience first. So who can tell me what these scenes all have in common? I know this audience has seen some of these movies. That's not where I was going, but I like that guess. What do these scenes have in common? They're funny. Who said that? Did you know that? Did you just guess that?
Like the 40-year-old virgin, I knew that was one take.
Kelly Clarkson improvised. And the from Wolf of Wall Street, improvised. I'll have what she's having, improvised. Now, yes, there's comedic timing. There's a skill set to improv comedy. There's also the fact that all of these actors, everyone on the set was paying attention, was actively listening, and they accepted their base reality, which is one of the fundamentals of improv comedy. When you enter a room, I don't get to pick what all your belief is, but I want to hear it. I don't want to negate it, and I want to go with it, which is exactly what we do when it comes to building trust and fighting that misinformation. This is why improv comedy is commonly now denoted as a health communication tool. And one very easy way to play this is to remember the base, that I'm going to accept the reality I'm given. I'm not going to negate it. So for example, Tony, if I were to say, please identify Mary's dream vacation if money wasn't a factor.
Bahamas with a glass of wine.
Bahamas with a glass of wine. And can you say yes and add to that sentence?
And perfect weather.
And perfect weather, and what else?
And her family.
And her family, and what else?
Yes, and then a first class ticket to Tokyo Disney at the new Fancy Springs suite. And just a private butler.
This went wild, and a private butler. So, this is exactly, as you can already tell, why something as simple as improv comedy, these basic fundamentals, can actually lead to quantifiable differences with these active listening skills, collaboration, empathy, paying attention, why improv comedy is actually getting its place in literature when it comes to communication, and why I do feel it's an incredibly important tool when it comes to pre-bunking information. Where is my audience right now? If I were to survey them, like a test screening, and I heard their beliefs, am I going to push them away and say, well, that's not right? Or can I find middle ground with them and say, yes, I saw that headline about myocarditis in the COVID-19 vaccine. It also scared me. But when I looked closer at the data, here's what I saw. Now we're on the same page. Now we're all defining Mary's vacation without saying that you'll never have Tokyo Disney in the Bahamas, which pretty cool if it is. Lesson number 2 comes from the great Diane Sawyer. Changed my life. Talking about making everything newsworthy for your audience. Everything has to be relevant to your audience. These are actual headlines from the last few days. If you look at all 4 of them, you can immediately start to slowly identify why they may have been newsworthy for a specific audience and a specific platform, like flirty male rifle birds, which hide your wife because they're pretty flirty. I learned that they can use their beaks and they can play their feathers like an actual instrument. That is awesome. People outside of a science newsprint may not find that interesting. But when we talk about our research, our clinical findings, we want to live in the world of trying to make them newsworthy. And you can do this even if you're talking to your students, even if you're making a post on Instagram, for example. By identifying as many of these variables as we can essentially make things newsworthy. This is a framework for how we actually pitch headlines. Proximity, is it happening to someone right now, close in your city? Timeliness, is it happening today? Should you pay attention? Is it sensational? Is the most famous person now been diagnosed with celiac disease? Or is it controversial? Celiac disease doesn't exist. Hillary, I'm just joking. But you can see how I can craft headlines any way I want them to, as long as I'm identifying ways to make them newsworthy. Dog bites man. Is that a fun headline? Man bites dog. Right? Now we're newsworthy. And what we're essentially doing is we're using these techniques from news to help our audience understand. And I'm talking a lot about national news. But this is a technique that we can use in any setting, whether you're giving a talk or you're speaking one-on-one to your patients. Crafting Persuasion is a book written by people who worked in the private sector in persuasion. And one of the most important points that they identify is when we actually speak, instead of thinking about my content first, I'm thinking first about my audience. Because what it does is it helps me identify how all of you make changes. Or what do you actually want to do with your change? What is the demographic? What is the health literacy level? What do I expect you all to think or know about me? From there, I can move on to things such as why should you trust me, why now, and now what content am I going to present you with? So one great example of how our audience can differ based on platform came a few weeks ago when 2 individuals very respectfully had a conversation, empathetic, charming, and were not mean to each other at all. And what we saw a day after was 80 million people and counting were viewing this across multiple platforms. These platforms have different demographics, different audiences, different age groups, different special interests. And it's not up to us to make an assumption about what they all gleaned from this debate. It's up to us to realize that our voices are needed in every single topic that is going to be tangentially pushed out from what is happening on national media. Now, I'm not saying that we should all be out there lobbying or sharing our partisan beliefs, but we should be ready to tell stories. We should be ready to share our research with our audience with topics that matter to them, rather than forcing them to say, this is what you should care about. And we've spent years trying to use data and science to convince people. One example is reproductive rights. I cannot tell you in 2017 to 19 how many times I've worked with news media to explain the difference between an electrical signal and a beating heart. This did not resonate with the public because they're like, doesn't matter. To me, it's a beating heart. It's not an electrical tube. But what is actually working in terms of getting the public to pay attention, in terms of getting people to actually go and speak to politicians who unfortunately are the ones who make scientific change by virtue of their power, are stories that are actually happening. What is the downstream effect? We understand that more than 99% of the people who are talking about it in mainstream TV. Physicians, people who work in healthcare, people who work in the public health sector. We're the ones who understand the stories of what it's doing to our patients. We are the ones who can talk about the March to Dimes data, that 35% of US counties fund maternity care. Millions of women live in what's called a double desert. There is no maternity care, and there is no access to abortion. And when you actually put that number and you put this map in front of people, all of a sudden the science becomes relatable. You can now imagine yourself, your loved one, somebody living in one of these counties. Now I get to include a bit of science about eclampsia. What would you do in this scenario? Kayla Marler was the public health commissioner of Fremont County, rural county in Colorado. And we spoke to her as part of PBS NewsHour. What she did was she proposed a family planning program. How controversial. She got funding to have family planning, to have access to STD testing. And there was a vote, 2-1, to remove her and remove her from her seat. On the board of health were 2 men and 1 woman. Which 2 do you think voted no? Shocker. But the point is, by telling her story and putting it out there and now painting a picture and saying, if you're in Fremont County and you're of reproductive age and you think that you may be pregnant and you need family planning support, you have to go to the next county. If you don't have a car, you have to walk to the next county. If you have an emergency, if you think you have chlamydia, you cannot get tested in this county. And now all of a sudden people are paying attention when they weren't paying attention before at the actual vote. So again, we can make so much of these stories newsworthy by simply thinking about our audience. Here's what's funny. I didn't know that Justin Baker or that Hillary Jericho would be here. Legitimately did not. You both are here. But these are all very audience-centric, newsworthy TikToks. And this is precisely why Diane Sawyer said to me, my last day of an internship, by making topics newsworthy, by paying attention to what my audience cares about, when I talk to millions of people every night on World News Tonight, I'm able to picture myself talking to them and being in their living room with them. It's one of the most powerful things I've ever heard from someone that I was able to take and then apply to bedside, to really think about the audience, think about what matters to them first. Last but not least, comes from producers and Judd Apatow, which is spot on, comes to telling stories. Judd Apatow, behind a lot of funny, famous movies, always talks about starting things with his grace note. Start by establishing humility in who you are as a person. He wrote Forgetting Sarah Marshall, amazing comedy movie, first as a drama, and then went back and made it funny to make sure that there was a grace note there, that it was a relatable story. This is a lesson that we've learned often in narrative medicine, and I'm just emphasizing it so people don't forget it. Now, if I were to ask someone, Aaron, good to see you, what TV show are you currently watching? You're evolved. Is anybody watching a TV show right now? The Bear, The Resident. We're going to get to that. That's a funny story. Oh, yeah. Think about the way the stories are written. Think about the way those hour episodes are written. They're written in a way to pull you in with different emotions rather than the salient message at the end, which is the exact same thing that we do in narrative medicine. I'm not drawing you in because I'm going to teach you. I'm drawing you in because I want to entertain you. Justin mentioned The Resident. So I was at a party, an industry party, and somebody asked me, do you watch medical shows? And I was like, not really. I think they're kind of lame. They're kind of trite. And someone said, do you watch The Resident? I said, absolutely not. After the pilot episode, when the intern is in the ER and the patient codes and the senior resident's like, you're on, intern. That would never happen, ever. If there's a code in the hospital, people are coming out of the ventilation system, right? There's no intern doing it with people going like this. So I said to the resident, these 2 people in front of me, I said, the resident needs new writers. Somebody needs to actually go and explain actual medicine to the writers. I'm sorry, I'm talking too much. What do you two do? And they're like, we're writers for the resident. The bright part of the story is they offered me a job. And the point is that real medicine doesn't need to be dramatized. What we're doing every single day in the hospital across the street has actual human stories behind it that people can identify with. Our brains want to feel this narrative. The whole concept of neural coupling comes down to when the storyteller identifies with an audience, these parts of the brain all light up. As many of these as we can use. When we're talking about our research and our work, the more we're going to hook our audience. So for CNN, I know this does not look like a health show, does it? Looks like a horror movie. Exactly. We were pulling people in because of shock. Something Killing Me is a medical mystery show that pulls people in to take them on a dramatic journey about what it's like to be there for families in these critical moments over a mystery illness. And I was working as the medical producer, and one of the most fun challenges we talked about is how do we get a story about rabies, about Niemann-Pick type C, about Naegleria fowleri, about a woman who was murdered by cyanide pill. How do we get a general audience to care? Lisa Chamberlain and I were coincidentally talking about this during lunch, is we get them to care about the subtext of science, of hope, of a family's struggle, of what people go through. Now, the biggest full circle moment I've ever had in medicine, crossing all my worlds, happened when an episode about X-linked myotubular myopathy aired while I was working at CPMC. So X-linked myotubular myopathy affects about 1 in 50,000 newborn baby boys. This episode aired, we were talking about it, and coincidentally, there was a family with X-linked myotubular myopathy in the ICU. And I was like, oh my gosh, what are the odds of that happening? And I walked over to the room, and they were watching it. And I was like, okay, if you I don't know, Nima's not here anymore, but someone calculate the math for me, the odds of this happening. And I walk in the room, and the mom looks at me and starts crying. And she immediately says, thank you. Thank you for telling the real story about rare disease and the fact that it's not that rare. And telling the story about what it takes for us as parents and not just throwing science at the audience. And we embraced, and it was this amazingly touching moment. The dad then runs out, and he was like, oh, I knew it was you. I thought it was either Sanjay Gupta or the other guy. Super honored to be the other guy, by the way. It's fine. I'm okay with it. So my thesis is that there's so many ways that we as a nation, from legal, from tech, to policy, to federal, to the individuals, to journalists, to all of us, can actually combat and make a more health literate, empowered consumer. And I want us all to not forget about the basic power of making information entertaining and stealing a little page from the Misinformation handbook, but for good, with evidence-based medicine. And I'll leave with the important facet that this is something we can all do immediately now. Anytime we need to persuade an audience to go out there and actually do it. So with that, thank you all. Thank you, boss. Really looking forward to chatting more.
Awesome. Thank you so much, Alok. That was amazing. And so finally, our last panelist, our next improv comedian is Dr. Sara Cody from the local Comedy Central she plays on. Dr. Cody is the director of the public health office at the Santa Clara County, and she basically is in charge of assembling data, public health data, and then using it to make decisions for the health of our people in our county. She basically is going to tell a story about as the public health director for during the COVID crisis, how she and lessons learned during that. So, Sara, thanks so much for coming. We're very honored that you're here.
Thank you so much. Okay, well, that is a hard act to follow, so I'm kind of wishing I went second. So I was thinking about this talk and what I wanted to say, and then I talked with Tony and I changed it up. So I decided to organize it lessons. And rather than talk about misinformation and disinformation and kind of the Wild West that we experienced during the pandemic, I thought I would just make it very personal about what I experienced, what I struggled with, and sort of how it came out. So, oops, there we go. I want to start with just some voices of what I heard outside my own home and then I'll back up and tell you a bit about the story of what happened.
You're an idiot, and you're a disgrace, and you're a coward. This is the United States of America. This is not communist China. You're a disgrace, Cody! Cowardice and a murderer! I don't know anybody that likes you. You are so hated by so many people. I don't know how you live with yourself. You're so disgusting. Who do you think you are? You answer to us, and you're going to answer to God. Tyranny, stop the tyranny! Medical freedom! Medical freedom! Medical freedom! You all get money. You had to suppress other information about hydroxychloroquine and ivermectin and vitamin D and all of these science is gathering all the information and then making a decision. All of us! And all of us! Not cherry pick! But cherry pick science, censored science, is tyranny. That's what we bow down to God and God alone. You are a criminal de facto impersonating public health officer.
Okay. So now that I have a few years to reflect, I can think about this and try to think, so why did this happen? Why did these people have these reactions, a minority, but what we know, like, what was going on with them and what can we learn? I actually learned a lot from my son, who was 13 when the pandemic started, and he got kind of interested in the protesters. He wanted to understand, like, why are they like that? You know, what are they thinking? Where I was thinking, I just don't like them at all. He actually had a curiosity about them, and I've developed a curiosity since. So just to back up a little bit, I'm going to tell you a little bit of the story before I launch into my lessons. So as many of you may remember, on March 16th, 2020, I, along with health officers from 6 other jurisdictions in the Bay Area, ordered our populations to shelter in place. And just to set the scene a little bit, here we are in Santa Clara County. Santa Clara County is a large county, about 2 million people. We're the largest in Northern California and the 6th largest in the state. And as the local health officer in California, the state law, there are a number of laws on the books that grant the physician health officer broad authority and responsibility to protect the public. So in many ways, the whole population living in the county is my patient, and I am charged with ensuring the protection of the population. So when the pandemic unfolded in January, here's a little bit what it looked like in Santa Clara County. We really started to worry probably about mid-January because our phones were ringing off the hooks with concerned everybody. Then the first case was reported in Washington State on January 20. On January 24, a Santa Clara County resident returns from travel in Wuhan and feels ill. And because at that time it was so hard to get a test from the CDC, it took a number of days to get this guy tested and to get the test result. But finally, on January 31, we learned that he tested positive. And so we announced our first case. And this was one of many press conferences that we had. And I just want to note at these press conferences, I had very little communication training, and I was just winging it, writing my own notes, stepping out in front of the cameras, and just talking about what was going on. So then 48 hours later, we had a second travel-related case. And we started feeling kind of nervous. But at this time, the state and federal message was consistently, the risk is low. Not to worry, everyone, the risk is low. No one was using the word pandemic. But we sort of spent a lot of time in a conference room thinking that if we just thought hard enough, we could, and squinted a little bit, we could figure out what the risk was. So we stuck this giant wall post-it on the wall and threw up some numbers. What we, the CDC would list numbers on their website, and we were comparing them to ours, and we said, wow, we're just 0.6% of the population, but we have 5% of the persons under investigation. And we actually have 18% of the positive cases in the country. So little numbers, but we started feeling like maybe something was a little bit different. And unbeknownst to us, a couple days later, the first person to die of COVID in the US was a woman named Patricia Dowd, who was a Santa Clara County resident. So things were happening, we just couldn't see it. Finally, at the end of the month, as you remember, there was a huge debacle with CDC testing. Finally, at the end of the month, we were allowed to run the CDC's test in our own lab, and we started testing immediately. And the very second sample we tested positive. And this was a woman who had been in a community hospital in an ICU for a week. We decided to buck the CDC's guidance and test her. She hadn't traveled outside of the country much. She hadn't traveled outside of the county, but she just seemed like she had COVID. So she was tested, and she tested positive. So this was just the third case of community transmission in the United States. And at that time, the cases of community transmission were sort of chalked up to, well, it's a random, rare event. No one was really talking about what community transmission meant. So this was a real turning point for us. And I was super, super, super nervous because I thought I need to thread the needle. I need to tell the truth. And the truth is that we have no idea what the risk is. The risk is unknown. But I also thought that if I'm communicating all of this uncertainty, people want to have an action item. There need to be something to do. And I remember this in patient care. It may be scary, but here's what you can do. So I thought, well, I'm going to advise people to start practicing not touching their eyes, nose, or mouth. And you can see that I look pretty nervous there. And I had scripted my comments, and I'm kind of reading them white-knuckled at the podium. After the press conference, I was super proud. I thought I really nailed it. And Rachel Maddow gave a shout out to Santa Clara County for clear, straightforward communication. And I was like, we're amazing. And then my husband was in Washington, D.C. at a meeting. And he texted me because he opened his iPad to the Washington Post landing page and saw his wife licking her finger. And then it went viral. This was in Daily Mail, India Times. So, lesson number one, communicating uncertainty is hard, very hard, but it's important. And lesson number two, communication is an art, and it requires knowledge and practice, and there are experts, some in the room. And so at this point, I learned that I needed some professional help. And so from thereafter, we had a communications person that I worked with very closely, and I would get all of my stuff out with her, and then she would coach me and tell me what to do and help read my body language. And I never, ever, ever went to a press conference again with anything but a single sheet of paper printed on both sides if needed. So now we're in early March, and you may remember the first 2 weeks of March, things went really, really, really quickly. So end of February, the Surgeon General is tweeting, stop buying masks. Masks aren't going to protect the general public. That was a message that was going out pretty frequently. And we had started to test more broadly. Still not that many tests, just a little bit. But as we tested, the sort of like pixels beginning to fill out, and we began to see a worrisome pattern. At the same time, we took a little set of those tests and saved them. We wanted to do a quick and dirty prevalence study because we really had no idea what the prevalence was. So we were testing people coming into county clinics who were flu negative and COVID positive. And the more data that started going, that we started getting, the more worrisome it was. And I, on Monday, March 9th, issued an order, the first I'd ever done for the whole population, saying more than 1,000 people can't gather, Sharks games are off. And I thought I would never recover. That was so difficult to do. But by Thursday, the 13th, actually by Thursday the 12th, the school superintendents across the county had decided to close schools. And the next day, I issued an order saying gatherings more than 100 would be prohibited. And on that same day, there was a letter in the New England Journal of Medicine saying, aerosol spread might be plausible. And this was in reference to a meeting in Germany where it looked like there was an asymptomatic person who spread. The following day, we got the results of this quick and dirty study back, and 11% of people who tested negative for flu tested positive for influenza. And that just absolutely knocked me over. So the following day, I got a call from my colleague in San Francisco, Tomas Aragon, and we started the conversation saying it's really confusing for the public. Santa Clara County is prohibited 100, then San Mateo went to 50. Like, we really need to get on the same page. And within about 30 minutes, Tomas and I started having a very different conversation. I was reviewing our data, and we looked to be in Santa Clara County exactly 2 weeks behind Northern Italy. You know, the way the case growth had occurred was exactly like Northern Italy. And we decided we really needed to issue a shelter in place. So then we began calling our colleagues and having conference calls, and that was a very, very intense day. We made the decision, got the lawyers on board, got the county administrators on board, and the next day announced this order requiring everyone, I think it was 6 or 7 million people among our 6 jurisdictions, to shelter in place. So, I think my third lesson there is that you absolutely have to tell the truth. So it was very difficult to give the message that, this was, no one else in the United States had done this yet, but we felt that this was the truth that was going on, and we needed to tell the public, and so we just did. I think there's a corollary lesson here, which is that it's important not. You have to tell the truth, and you can't message because you want someone to change their behavior, because that will backfire. So for example, the message of you don't need to wear a mask, the real message was we have a severe shortage and we don't want to cause panic, so we're going to tell you you don't need one. But that wasn't true, and that definitely backfired later. So the impact of that order, these are the data, these are the facts. Santa Clara County had a significantly lower COVID mortality as compared to the state, and about half that of the country. These are data, just about 18 months of data, February 1, 2020 to July 2021. However, that's what I saw. Those are the facts that I saw. But that's not how a minority of people experience this. So this is a sidewalk chalk communication in front of our home, and you can see there the data does not justify the lockdown. Stop lying. So what I understood the facts to be was not a shared understanding. Dr. Cody is not my master. Fair enough. This was a I often wish that the county executive would heed this cry. He did not relieve me of my misery. But my lesson here is that facts and values are different. And I didn't really get this for a long time. I mean, as far as I was concerned, the fact I was communicating was we can see in the models, we can see in the data, we're having exponential growth. We know enough from data around the world that the population is, not immune, and that this will cause death. And we don't have any tools. We have few masks, few tests, no treatments, no vaccine on the horizon. This is the tool that we're going to use. I felt that was the fact. What I didn't appreciate is that what I was really communicating was policy, and policy is more than fact. Policy incorporates your values, your culture, and many, many other things. And so what I was implicitly communicating was my values, our values as a county, that we valued life over liberty. But for many, for a subset, they actually valued liberty above all. And therefore, what I was doing was perceived as being an authoritarian dictator, anti-democratic tyrant. So later in the pandemic, we got more sophisticated and had ways to incorporate community input and community values. And much of our messaging around the vaccine when it came was very segmented and driven by community engagement and community voice. And so we had a lot of input for how to roll out vaccines in particular communities, and a lot of the media messaging was done by particular individuals, resident leaders, people known in communities across the county. So this is one example, and another example of locally known people who could communicate why they got the vaccine and why it was important to them. So lesson number 5 is that the messenger does matter. You may remember that we were in this continual dance between the virus and the vaccine, the variant and the vaccine. And so these are data, local data from Santa Clara County, and you can see the green are the case rates among people who are vaccinated, fully vaccinated, and the orange is people who are completely unvaccinated. And so during the Delta wave, we were messaging that the vaccine, the vaccine is amazing. And you get vaccinated to protect yourself, you get vaccinated to protect your family, to protect your community, because it, for the most part, you didn't get infected if you were vaccinated. Well, it all changed during Omicron, and you can see that little spike in the green, not as it reduced your chances, but it didn't really prevent it. And I'm not sure we did a great job transitioning the way we talked about it and communicating that, it's a dance between the variants and the virus, and things are going to change, and expect it to change. I don't think we did enough talking about that people should expect things to change. And so a lot of people came away feeling like the vaccine doesn't work. So lesson number 6 is, as the evidence changes, so too must the message. And I think the corollary of that is that we have to anticipate that science, we have to talk about how much that science is change, and anticipate that our message is going to change too. And my final lesson is care first. This was something that I learned from this woman who sort of pulled me back from the brink when I was struggling to communicate about the pandemic. And I would talk, and she'd say, Sara, like stop, just think about this. Why are you doing all of this? And I would say, because I don't want people to be sick, because I don't want people to die, because I feel responsible, because she said, that's right, because you care. And people may not know that unless you say that. So that's how you begin speaking. You first talk about why you care and why this matters to you. So I found that really, really, really helpful, just in any communications that we do, that care first. So those are my 7 lessons that I learned. I'm not sure that, I think we did a pretty good job. I think we could do much better next time. And I think with these lessons, I hope that it would build a bit more trust. We may never reach the folks that are yelling outside my home, but maybe we'll reach them a little bit, and hopefully we'll develop a bit more trust for when the next public health disaster comes. So thank you very much. Thank you very much for inviting me to this panel. And I look forward to questions.
That was wonderful. Thanks. I want to invite the panelists to come forward and sit down on on the comfy chairs. If you have, start thinking about your questions for the panel. Here, come up to the microphones and ask questions.
Don't be shy.
I'll start out. So each of your stories was very poignant, but each of them had a point about education, about your audience, and then both the person delivering the message and the person receiving it. Just if you go around, maybe for you, what would you recommend in terms of education or training for the next generation to best help with the message?
Do I have to go first?
You do.
I'll talk about training, because I think that there's these basic skills that are taught across many other disciplines, whether it's marketing, journalism, politics, especially in the entertainment industry, that we could really benefit from in training. And I've been lucky enough to experience some medical schools actually embed basic journalism and basic improv comedy in some of their orientations. And I think these very small tools can make such a huge difference when it comes to one-on-one patient education, but also in basic information campaigns and really thinking audience-centric, like we talked about, establishing that grace note. I think it's huge. I didn't realize until I was working in the hospital how many parallels there are between patient care, making television, grievance counseling, and improv comedy. So I think just looking at, say, communication training, I think, can start as early as even when kids are in pre-med.
I would wholeheartedly agree. I mean, I think there's a lot in common between communicating with a patient and communicating with the public. I mean, you communicate with the public or media, you communicate with patients. And people want to be assured that you are a human and that you have empathy and humility and vulnerability. They want to know. I think that's really key.
Can I just add that we also there's trainings available that I think we just need to tell people about. Our marketing communications department has like trainings available.
I'm here to tell you about what we can offer.
Yeah, it's coincidence. Like there's trainings available that we literally just spread the word.
Yeah. First, I think that all of you guys are extremely busy. So I think that pediatricians, you spend more hours working to treat patients. I feel bad if we add those burden of communication to all of you who overworked. Each minute count. So if you think about training and education, I think that it's really, that collaboration with people that do communications, that's the way to do. And also think about social media platforms. Use those platforms, make them accountable. They should be the ones. Think about communication plans. Support all those communication messages we want to deliver. I do think that it's a community, I think, all working together. So that's a way maybe build to deliver all those messages.
So my name is Erin Digitali. I work for the Office of Communications at Stanford Medicine. We have a whole team that can help with many of the issues that were discussed today. Most of us on the team went through the pandemic. Some of our team worked with Dr. Cody quite closely. I was the one who wrote the press release when Stanford developed a ELISA-based assay for COVID in my cousin's guest room because we had evacuated because of wildfires. So we have a lot of on-the-ground experience and are happy to talk through difficult communication problems with you. There were several doctors on our infectious disease team who had not done media before the pandemic. Bonnie Maldonado had done tons, she's a star, but there were several other people who really were very nervous about doing it, and we were able to help guide them through. And we have some people who are fire tested now because of that experience, and we can help anybody who wants to do it get there. So I just want you to know that that's a resource that's available to all of you, and we all really love what we do. So and even if you don't you're thinking, oh, I'm not a pandemic doctor or whatever, we can help you get your message out. So reach out to me, please.
Thank you. What a great panel. My name is Justin Baker. I'm the chief of the Division of Quality of Life and Pediatric Palliative Care. I don't have any more pins that Alok is wearing, so please don't ask me. They are wonderful, and I have more in my office, and I'm happy to provide them at a later date. So, Alok, you talked, each of you kind of represented a group of, maybe we in this room might call fringe, or this group who, no matter what you tell them, is not going to listen to you, or the people outside, your house, or the actual nutritionist giving the TikTok. I worry because in pediatrics, those people are having children who potentially are not vaccinated or otherwise. And so thinking about our audience and recognizing we have to reach out to that group of people, what would be your suggestions for trying to do so? Because I think that those people are significantly further away from us as a medical community now after the pandemic than they were before. And I'm wondering how we can start to come that direction or start to bring them our direction.
Should we go in the reverse order?
Yeah, sure. I think that is partnerships. If I think that also, Sarah, I think that you have on your slides, is go to those communities. Maybe it's a church, maybe it's the YMCA, maybe it's some other programs. And those people in the community, I think those are ones, that's the one we can reach the people that usually we don't reach. Not everybody like people come from Stanford, but they trust people that they're neighbors, they go to church together, they see in the farmer's market. So I think those are the approach to go. It's really first, but it's not really we want to just give them. First is want to hear from them. So what's the community's needs? How we can help? What's the best way to help? I think those are ones that's a way to reach the populations that we cannot reach. Back to I think my case about that nutritionist on TikTok, I think that is another type of solution. It's what's the incentive, right? So when it's really, she gets those kind of, I think she has incentive to almost like clickbait, to share those kind of information. I do think that change the incentive, it's a policy level, how should those incentives we should change to downgrading all those content and upgrading all the content that we think care. That's another, I think both ways might work to reach the population.
So are you recommending more TikTok videos from Erin Digitale?
Yeah, I do think that exactly. I do think that will be part of those information ecosystem. Make us be in there. They see those faces. That's the best way to reach.
And we do have a big institutional social media presence, which we are happy to have anybody get involved in.
I still, well, one is I think that people will listen to their pediatricians more than almost anybody else that's official. So you're in good shape. I think they'll listen to a pediatrician more than they will to someone from government. We of course use particular messengers with sort of high touch, boutique messages, and that helped us particularly with vaccines. I think we've really struggled with social media because of the laws that I'm sure Michelle Mello talked about. Once we have a troll or somebody who says something outrageous, then all of the content is about that, and it's not about the original post. So I think that's really, really tough to manage with the laws as they currently are.
I was just going to add, for me, it's been actively listening. Kind of similar to, Sunny, what you were mentioning, is there are times when there are groups who will say, we're not getting vaccinated, here's the reason why, or they're going to share a paper that may not come from a credible source, and I'm not going to give any advice. I want to literally learn and understand why this population believes this, and then there's a potential for that one-on-one communication. And the example that came to my mind is there was a paper that was circulating last year about all the sudden deaths that have happened in young people who have been vaccinated since 2021. And this was being circulated all over social media. Patients were referencing it to me. It was getting sent to me across the news world. Producers are showing it. If you actually go and look at the paper and their anecdotes, there are people who had, quote unquote, had cardiac arrest in 2019 were included, people who had died from cancer, someone who died from an overdose in a hot tub. But this paper was coalescing all of them and saying that they all had sudden cardiac death from the vaccine. And so I feel like by being able to truly understand where our audience is getting their information, especially the ones who are reticent to listening, you can then develop a media strategy.
So the spillover, as you know, is not just anti-COVID vaccine. We have a very effective HPV vaccine to prevent 7 cancers, and even in Palo Alto, the complete uptake rate is 60% in an educated community. How do we depoliticize vaccination? How do we remove this radicalization based on political party lines from our vaccination programs?
Well, I mean, I think this is a huge challenge, and there's certainly a lot of discussion among health officers about when to use health officer authority and when there might be unintended consequences of using that authority. So with vaccine mandates, for example, the intent, of course, is to ensure that there's high vaccine uptake to protect the whole community. But if there's not a shared value in why, even if the data show that increased uptake is more protective, if there's not a shared value, it won't go anywhere. And so a lot of health officers that I know are increasingly uncomfortable in mandating anything regarding vaccines. And so that means that we have to have all of these other strategies of encouraging uptake of vaccine. And I think, to your point, really understanding why, what are people afraid of, or what are people worried about. I think any time that we do something that makes someone else feel shame, we've lost. We've absolutely lost. So we just have to be extraordinarily careful to listen carefully, even when what folks are saying feels pretty outrageous.
I think it's easier said than done.
Oh, for sure.
But I feel like it's also important for us to be nonpartisan, because we never know who we're talking to, who we're gonna push someone away from a certain belief. I gave a talk, and I was talking about one specific hospital that was refusing birth control to all their patients, even those where it was medically indicated. And someone came up to me afterwards, and she said, "I just would like to give you some feedback, but I was turned off by when you presented that statement." And in my mind, I said, "I made an objective statement." And she said, "Yeah, but I could tell on the look on your face that you disagreed with that hospital. And as a practicing Catholic, that is part of my core belief." And so truly understanding that how we separate objective evidence, I feel like we can try to reach the half of the country who may not believe with our views.
I think that's the sad reality is everything here. Every issues become politicized. Previously, 5 years ago, health issues is not political issue. Now it's become it is. So there's, I think that the solution-wise, I think that here's different ways. At Stanford, for example, deliberative democracy. We bring people together and deliberate. Actually, that find out can reduce polarization. But those are so hard to scale. I think all those things that we want to build, the core is about trust. I think the polarization is about how to rebuild trust again. All those solutions, the ways we can really build trust, it really cannot be scaled. It takes lots of long time, one-to-one, people talk, be authentic, show care. I think that's a real challenge. I think it's not health, but overall, how we can, in the United States, have those fundamental approach and invest in those long-term trust building. That might be the solution for all this when we don't trust organizations anymore.
Hello, I'm Hillary Jericho from MCHRI and the medical director of the celiac program, as Alok put in my video up earlier. First, I just want to say thank you all for coming today. Your talks were amazing. As someone who's trying to get into the social media platform, I think a big fear of mine is putting something out there that maybe at this exact point in time is accurate, but in 10 years isn't going to be. And obviously everything on the web, it never goes away. And I guess what are the steps to ensure you're giving out reliable information and being held accountable for the stuff you might have put out in the past to ensure people aren't referencing that down the road when it's no longer accurate anymore? So I'd love to hear your thoughts on that.
Yeah, I can guess. I think all of us care because we are scientists. We do want to get the most accurate information. So we have those kind of burden of proof on ourselves. I do think that if you think about social media, it seems we always have those thoughts about if you put it there, it's always be there, but it seems that's not the case. So I do think that the best evidence now you put there, it's the best evidence. If after years things change, as I think Sara mentioned, things change, we update our messages. I do think that's the best way. What we know, that's really challenge about communicate under uncertainty. we just don't know that. But if that's the best evidence so far, we show them on social media. Here's evidence. I'll make these claims. And using storytelling strategies. I think that's a best communication plans. We can always be falsified. That's scientists. That's part of what our job do. But, yeah.
The only thing I was going to add is if we're explaining pathophysiology, the odds of that changing, maybe it does, maybe it doesn't. But if we're talking about data and having that humility to say this is what it is right now, having primary research there, and then I think I have to be the fun police and remind everyone that everything that we put out represents Stanford or your institution, or your maybe, and just to realize that we should not be editorializing the news or giving individualized advice, because again, there is always the potential for someone to spin something you say. So I would say when in doubt, if anybody wants to put out a statement that may be misinterpreted, to talk to the Office of Communications and say, I want to speak about this. Is there a medium at which I could do it? Are there do's and don'ts about putting something out? And then by having that primary research, I cannot say a sentence on ABC News without saying this is the actual RCT.
Maybe I can ask Kristen to talk about if you know the answer, and then you can put it out there. But if it's a machine learning approach with a lot of hallucinations, you'll have to know and be AI literate to understand what to say. Maybe you can chat a little bit about that.
Yeah, I was going to ask a little bit. So I think, I go and talk to people about, I go and talk to physicians about AI and how not to be scared about AI. So how do you think about changing the message a little bit for physicians? Because I think there's still a lot of kind of misinformation about how these tools can help us in our world. And so that's maybe that's not by reaching them through TikTok. I scroll Instagram Reels a lot. So, so how do you think about reaching physicians for some of this information, misinformation, particularly around AI or tools to help us do our job better?
Yeah, I can get started first. First, I think that physicians should be cautious about AI. So if they are just really accept that, I think it's more problematic. Then they have those cautious. We just did a systematic review of all the papers about AIs and how people think about whether they are avert to AI or appreciate AI. So it's actually the majority of people, they have this algorithm aversion because they're concerned about mistakes, and especially those high-risk decision-making in pediatrician world. I think that the best way to communicate about AI is really, I think that have almost like ground truth about what AI are good at. For example, I use AI to write emails. I'm really happy with that. But maybe use AI to make a decision about which PhD student I should get or not. So maybe not. So it's really all those ground truth about what AI's advantage or a disadvantage. And more importantly, how to use that. If that's the prompting or that's how to fact check. If you think about AI literacies, for pediatricians, if you get answers, what are the simple 3 steps you can do to fact check about the information? And what are some cues you can see there are some mistakes in that information one cautious? I think that may be the best way. And trying to keep updating, because today's GPT very different than what GPT come out next month. So all those changing, find a ways, faster prototyping, almost like you're trying to catch up. So here are the main points that watch out. I think that I would do for that.
In the model I was talking about with the crafting persuasion, it's A, B, C, D, and D and E. D stands for delivery. So what platform are physicians using, depending on where you are, to get their information? And some hospitals have publications, like we have Scope, we have interdepartment emails where you could potentially reach a physician audience. Then physicians are largely the audience on places like STAT, Medscape, Doximity, conferences, et cetera. So you think then, okay, could I get something out to physicians by using one of these channels as opposed to Snapchat, where there may not be any physicians? And what I found with AI specifically, we did an article with Medscape, is that using specific examples of AI all of a sudden got physicians from rural practitioners to academicians to view AI and say, oh, that's a tool. People didn't know that Pew's was considered an AI tool, and that the sepsis, these calculators is AI. They think that AI is some robot. Or ways you can use ChatGPT to file insurance claim denials, which that story from a urologist doing that went viral because he was able to generate all these and made a video about it. or that you can use ChatGPT to write insulin directions for a school nurse in Spanish. True story. And so all of a sudden people see, oh, this is how it actually could help my workload. And then take that information to a startup and demand a consulting fee. Just saying.
Hi, Sneha Ramakrishna, pediatric oncology. As an oncologist, I live in the world of hope that we can make things better. I think at Stanford, we work very hard to try and find that hope for the future. And I've been thinking about, based on all of your talks, the combination of trying to, hope is a very powerful and also sometimes dangerous tool. And so sort of thinking about how we use the hope of medicine, but temper it with the knowledge that we don't have all of the answers and we may not have all of the answers. And especially in the COVID pandemic where we didn't know what we didn't know, and it was very difficult to navigate in all these different situations. How do you combine the power of hope with the deference to what we don't know to potentially improve sort of the trust of medicine in the community?
I feel like you just did it.
Yeah,
Wow.
I was gonna say,
that question, I was like, I'm done.
ask an oncologist.
Wow, that just got me emotional. Anyone?
Yeah, I mean, I think you beautifully articulated that there's a balance and that there's a tension, and you do have to you have to tell the truth and you have to preserve hope.
It's the beauty of narrative medicine, telling that patient's story. Then all of a sudden, a rare disease or gene therapy that happens in one disease all of a sudden becomes a story of hope that people can find their own value to. I think that's why a scientist who may not think their story belongs in mainstream media needs to view it from a narrative lens, go to their Department of Communications, say, I want this story out there. And I think those stories are hope, are so powerful. Recruitment, clinical trials, morale, funding, everything.
I think that's right. So if you think about hope, it's really about storytelling. The hope is, if you think about the definition of hope, it's really that you accept uncertainty but still have a positive outcome expectation. So that's hope. I think that is, if you will, exactly communicate that with the audience, right? So here's some uncertainty here, but here's also the reason why we still being positive, have those positive outcome expectations. Have those, I think that's Sara's story about just care. I think that is hope. When you have people care, that will see that why we can still be positive about that.
Just to add one more thing to that, I also think one of the ways I think about this, because I do this all the time in storytelling, especially for pediatric cancer, is to describe as much as I can how far we've come. Because people may not know that 40 years ago, most kids with pediatric cancer died. And how did we get there? And what are we doing now that builds on how we got there? So sometimes getting down into the nitty gritty of like, what's the Children's Oncology Group and how did that come about? Telling some of those stories gives people a sense of, oh, we have tools to tackle these very hard problems. That I think is a piece of hope, saying there's a method to how we do this.
So we have just a few more minutes left. So maybe one final question about the future. And question, are you positive or negative about the future in terms of communicating medical breakthroughs? And also, if you had to do one thing differently here at Stanford or in the community at Santa Clara, what thing would you invest in to actually make what you do better? Sunny, you want to go first?
Yeah. I'm actually really, I'm really hopeful because I think adolescents actually there's hard time, but most of them turn out to be fine. So I think that for that also I think that there's so many new tools from the large language models, for even those short video platforms, all those technologies I think that can help us to communicate our messages and then to really improve the outcome we care. Maybe it's mental health, maybe physical health, or maybe it's improve of care, all those different outcomes. So I'm really hopeful. If I can do differently, I think that what I will do is think more deeply about how I can build partnerships, understand all those people that are different than me, and what are some best way to reach out them, and also how to think about working together, build those foundation ways, so we can have the space, time, and even resource to rebuild trust. So that's what I.
I guess in my world, I think a lot about how to communicate the value of prevention, because when you prevent the bad thing, what you see is nothing.
Right. And your job is easier.
So when we're totally on our A game and just like nailing it, you won't even notice us. It's only when we go way off course that you'll say, "What on?" Then you'll know that we're not. So, I mean, I think this has been a struggle in public health for a long, long, long time. Is how do we communicate the value of prevention, and how do we use stories? Like, what kind of stories could help highlight the bad thing that didn't happen? So it's sort of like a negative space problem. So you're going to help me with this.
And then maybe just one follow-up quick question. So the morning session says that you can use AI models to actually predict things that are coming in the future. Do you think that's possible for public health?
I don't know.
To a degree, I do think it's possible. I'm not nearly the expert in machine learning, but even if we looked at the probability of the next pandemic, right, or what a specific community looks like, and I think, to Aaron's point, I think we have a more scientifically curious population. The pandemic ripped this veil off of so much of what is happening in healthcare that people now are paying attention, and they have a skepticism, and whether they're reading Nature or Joe Rogan's podcast transcript, like they're asking these questions, and I feel optimistic, and I feel like we're paying attention to not only the scientific skepticism, but we're a little bit more in tune with our audience than we were before. And the example I'll give, social determinants of health, not new, 70s, Robert Wood Johnson, we've been talking about it for decades, but somehow it became this hot button term in the last few years. But in the beginning of the pandemic, you saw people go on the news and say, stay at home and practice social distancing. For a family of 5 in a single bedroom where the earner is out in the community, this is not a relatable phrase whatsoever. You've immediately lost your audience before you even started. And I feel like we're a little bit more in tune to how to reach people who may not be where we expect them to be when it comes to resources and health literacy. Awesome. I'm going to throw my chair. Sorry.
All right. We're at time now, so I just want to thank these wonderful panelists. Thanks so much for coming. It was a great discussion today. Thanks so much. So with that, this ends the session today. Hope you had a great day. We learned a lot about information disinformation, about how to get information, how to clean information, how to put into a legal framework, the risks and benefits, and then also how to communicate it with a little bit of humor and truth-telling and caring for our patients. And so thank you very much for basically attending today. Is Netta around? Yeah. I just want to, and Mary Chen. I want to just thank two people right now coming to the front. Netta Miller and Mary Chen. These are the people that actually put this on, that we basically rely on heavily. And so just wanted to thank you again for all of you did today, for this organizing this, for this entire session. We have a little thank you to both of you. And thanks so much. All right. And have a great day.